and I'm an anesthetic and critical care clinical fellow now working in the United Kingdom, but I previously was trained in Hong Kong. Today, I'm going to share my presentation about shock interpretation with echocardiography in the intensive care unit. So echocardiography is important of ICU patients and shows the advantage of non-invasiveness and can be rapidly applied to the patients. In the acute situation, a basic study often gives immediate results, allowing for initiation of therapy. Today, I will review some evidence about transthoracic echo principles and concepts in the intensive care unit. So echocardiography in ICU bedside greatly differ from cardiology outpatients. Many patients in ICU are mechanically ventilated. Intermittent positive pressure mechanical ventilation gives cyclical changes in intrathoracic pressure, which change the loading condition of the ventricles. Another pitfall is that the interpretation in ICU needs to take into account of different effects of inotropes, vasopressors, cardiac pathologies like a diastolic or valvular dysfunction. Some echo guideline is based on studies done under spontaneous breathing instead of mechanically ventilated patients. Therefore, with the reference range, whether they can be applied to ICU might be controversial. There is an important concept before we start doing echo for patients in ICU. This is whether we are asking the right question in the right time. If the patient is not in circulatory failure or shock, you don't need to perform an echo. Even an individual that is healthy can be fluid responsive. Without an appropriate indication, an echo will not provide us the right answer. Same as any laboratory test, the concept of pre-test and post-test probability applies to echo. If the pre-test probability is very high, you probably don't need to do assessment, while on the other hand, if the probability is very low, our echo might not justify your intended treatment. Therefore, your patient must have inadequate perfusion, and there must be uncertainty to the correct treatment that your echo might be helpful. Shock is defined as life-threatening circulatory failure associated with inadequate oxygen delivery to the cells. Circulatory failure and shock are common in ICU, and they are multifactorial. There are 4 major mechanisms, either alone or in combination. Competency standards are well established worldwide by different organizations from both basic and advanced critical care echo. A rapid bedside assessment using only 2D and M-mode echo demonstrates major underlying abnormalities rapidly in the acute scenario. Overall structural parameters, including LV contraction, ejection fraction, segmental wall motion abnormalities can be identified. These parameters may give us some clues to differentiate what cause of the shock it is. For instance, it is more likely to be hypovolemic if we see kissing ventricles or small LV and diastolic area and collapsed IVZ. However, advanced techniques involving the use of spectral Doppler and tissue Doppler use much more information. For instance, we use myocardial systolic velocity to estimate the contractility, the LV outflow tract velocity time integral to calculate the stroke volume, and cardiac output, which is more accurate than ejection fraction by Simpson's method. The American Society of Echo algorithm for diastolic dysfunction recommend parameters, including but not limited to the mitral annulus E over E prime, the mitral inflow spectral Doppler EA ratio, and the TRV max. There are many problems with static measurements parameters. Unlike outpatient clinic, they are very dynamic and also with different fluid status, vasopressor infusion dose, and positive pressure ventilation setting. For example, a struggling LV may appear normal in the presence of inotropes. The interaction between the left ventricle and the arterial system, known as the ventricular arterial coupling, is not considered by static parameters. Furthermore, certain parameters and reference ranges are based on expert consensus, and the rationale comes only from single center and epidemiology studies. Parameters valued in critically ill patients are uncertain. A recent cohort study aimed to validate the 2016 American Society of Echo Diastolic Dysfunction guideline against the right heart catheterization invasively, measured by measuring the wedge pressure. the correlation between the diastolic function grade with the echo with the invasive methods was surprisingly poor. There is no validation in ICU ventilated patients, and the applicability of these numbers to ICU patients are controversial. Static parameters reflect preload at some point on the Frank-Starling curve, but does not correlate, demonstrate a capacity to move along that curve. Dynamic indexes based on the heart-lung interaction are likely to be better. These techniques include passive leg raises, fluid challenges against stroke volume measurements, or variation in the systolic pressure, house pressure, stroke volume changes in intrathoracic pressure induced by mechanical ventilation. For example, the passive leg raise test has been widely studied, and it has a very high sensitivity and specificity. And the current surviving sepsis guideline also recommend the dynamic measurements to be used to predict fluid responsiveness. And here's a summary of an approach and important consideration suggested by experts to use transthoracic echo to assess the dynamic fluid responsiveness in the critically ill patients. Even though dynamic index are suggested or recommended, they come with limitations. For example, repeated large fluid bolus might end up overloading the patients when you realize there is no longer any fluid responsiveness. And mini fluid challenge, for instance, only 100 ml of fluid bolus might avoid overloading, but the change in the cardiac output might be too small to be detected by echo. Investigators have tried to identify optimal cutoff for fluid responsiveness under echo. A study has tested whether the transthoracic echo, the VTI, velocity time index variation after a small fluid bolus, 100 ml of fluid, can predict fluid responsiveness and validate against the final fluid responders. The best cutoff value the study found is 3% of change in the VTI, which is lower than the sensitivity of an echo. So the study suggests a lowest reliable detectable change measured by echo should be a 10% change in the stroke volume. Another method is the stroke volume variation. The stroke volume is estimated by the LV outflow tract velocity. The respiratory variation under mechanical ventilation is used to predict the fluid responsiveness. A stroke volume variation of more than 12% accurately predicts fluid responsiveness, having a high positive predictive value and a high negative predictive value as well. But it is limited in spontaneous ventilating patients or patients having arrhythmia, poor lung compliance. So there is a lot of limitation of its use in ICU setting. The IVC diameter variability has been used widely in the past. A large negative prospective study has shown a poor sensitivity and specificity of the IVC diameter compared to the strict leg raise testing. And there are multiple disappointing meta-analyses with poor results. An expiratory occlusion test for detecting fluid responsiveness has been shown with a promising predictability, but their use are limited in various clinical situations, and it is often labor intensive, requiring maneuvers on the ventilator to test it. On the other hand, there is a newer concept of interaction between the left ventricle and the arterial system, which is named the ventricular-arterial coupling. It is now recognized as a key determinant of global cardiovascular performance. Studying the left ventricle efficiency requires not only investigating the properties of LV itself, but also the modulating role of the arterial system on the left ventricle performance. We take the physiological model of the pressure volume loop, which is shown here, into consideration and assess the relation between the arterial elastance, which is the EA, against the end-systolic elastance of the left ventricle, which is the EV. The VA coupling is the ratio between these two figures, and it gives the efficiency of the cardiovascular system to provide adequate perfusion to the organs. The optimal ratio should be 1:1. The VA decoupling can lead to severe cardiovascular dysfunction and hemodynamic impairment, leading to circulatory failure. The concept of VA coupling plays a key role in cardiovascular function is not new, but our ability to detect it on the bedside is new. There is a newer concept on if multiple pressure volume loops are created for the left ventricle using the invasive method. You can see the multiple pressure volume loop here. Then you can draw a line joining from the beginning of end diastolic volume and end systolic volume, which is consistent against the various pressure volume loop. The gold standard for measuring the VA coupling is the invasive measurements, but it requires a conductance catheter and manipulation of the loading conditions. Therefore, there are some non-invasive single beat methods that has been developed and validated against the multiple beat gold standard method. The recommended single beat method was developed by a Taiwanese and Japanese study. It is based on a measurement of diastolic arterial blood pressure, systolic arterial blood pressure, stroke volume, ejection fraction, and the ventricular elastance. The resulting curve were remarkably consistent despite variation in underlying cardiac diseases, contractility, loading, and heart rate. On the basis of these findings, the end systolic elastance can be estimated from a single beat at the bedside of ICU. But the problem is that it is not widely validated against studies after the initial study. Being said that, it is still being recommended by the European Society of Cardiology as the choice of VA coupling assessment. For diastolic assessment, the 2016 American Society of Echo Diastolic Dysfunction guideline is still the gold standard in ICU setting. Recent study has used diastolic elastance on this curve, which is a surrogate by dividing the left ventricle pressure changes E over E prime against the stroke volume, which is in theory offering benefit of evaluating the dynamic changes between relaxation and contractility. Finally, the arterial elastance, this curve, the effective arterial elastance reflects the total afterload imposed on the left ventricle and represents a complex association of different arterial properties, including the pulsatile component and the non-pulsatile component. Clinically, the arterial elastance can be defined as the capability of the arterial system to increase pressure when the stroke volume increases, and can be estimated with end systolic pressure divided by the stroke volume. While the end systolic pressure can be derived from the systolic blood pressure, a study has shown that it is 0.9 times systolic blood pressure equals to the end systolic pressure. And previous studies have demonstrated that this correlates very well in patients with different ages and different vascular properties. So putting theory into circumstances of cardiogenic shock, on the pressure volume loop, impaired contractility will result in flattening of the end systolic elastance. Pathology causing impaired LV contractility might also affect the LV compliance, causing the end diastolic elastance to shift upwards. Hypotension trigger the activation of autonomic nervous system, resulting in vasoconstriction and increased arterial tone. Therefore, the arterial elastance will drop. Interpretation of the echo finding in cardiogenic shock could be complicated, as impaired LV systolic function with diminished ejection fraction and stroke volume can mask the effect of a sudden change in the heart loading condition. On a distributive shock or septic shock, there is a significant decrease in the systemic vascular resistance. So there will be a drop on the arterial elastance curve. The LV contractility will increase due to the autonomic nervous system activation. So the end systolic elastance will rise, while the end diastolic volume will drop. So the stroke volume will increase. The left ventricle will appear hyperdynamic. This table summarizes dynamic changes of parameters in different types of shock. In chronic cardiovascular disease, the main effective therapeutic intervention have been demonstrated to improve VA coupling, thus affecting the clinical outcomes, and inotropes vasopressors can improve the VA coupling. But the main limitation is the lack of study to demonstrate the clinical benefit of hemodynamic algorithms that include VA coupling. So here I will show you two clinical cases The first one is a 57-year-old man admitted for 2 weeks of constipation and abdominal pain. CT showed a suspicious closed loop obstruction. He was brought to the theater for laparotomy for transverse colostomy. He was kept intubated postoperatively and transferred to the intensive care unit for stabilization. Upon arrival to the unit, he is pyrexic with a MAP of 70, heart rate of 102, and on NORAD infusion of 1 mics per kilogram per minute. He was on a positive pressure ventilation requiring oxygen and a PEEP of 8. He requires a moderate amount of vasopressor to maintain the perfusion pressure, which means he is clinically in shock. But whether he's septic, can he be fluid responsive, or is he hypovolemic, is a question. So to answer the question, we've done a transthoracic echo. Based on a very crude assessment on the parasternal views, you can appreciate the kissing ventricle here, which is hyperdynamic. There is no obvious abnormality of the contractility can be seen. We didn't measure the wall thickness here, but it is very likely he has some degree of ventricular hypertrophy. The apical 4 chambers, you can tell the good contractility of both the left and the right ventricles. Spectral Doppler and tissue Doppler were used here to assess the ventricular feeling pressure, which showed possibly some degree of diastolic dysfunction. IVC is not particularly collapsed, and there is no obvious variability here. So a fluid challenge of 500 mL of fluid was performed with a stroke volume before and after fluid being measured. And there is a 15% increase in stroke volume, which means the patient is fluid responsive. Despite a positive fluid responsiveness, there is a considerable increase in the feeling pressure after the fluid bolus. The end diastolic elastance is increased. The overall picture suggests a hypovolemic shock with some degree of diastolic dysfunction, possibly with pre-existing LV hypertrophy. The normal to slightly elevated arterial elastance suggests septic component is less likely. Despite the fluid responsiveness, the fluid challenge has to be done with caution due to abnormal ventricular feeling. Close observation should be done under smaller fluid boluses. The patient gradually improved after slow fluid replacement and was extubated and discharged after 2 days. This is another case with a 73-year-old gentleman admitted for chest pain, respiratory failure, and fever. He has a past history of diabetes, hypertension, TIA. He was complicated with respiratory failure requiring intubation. And cardiac enzyme is elevated, while ECG showed ST depression in lateral leads. He was on minimal dose of vasopressor, and his fluid balance was negative 1.5 liter after admission. And the chest X-ray showed widespread bilateral infiltration, and we are uncertain whether it was pneumonia or fluid overload or ARDS. So we've done a bedside transthoracic echo, and you can appreciate the severely impaired LV contractility, dilated LV chamber, akinesia over the anteroceptor region, and hypokinesia over the basal and inferoceptor region with an apical ballooning on the left ventricle. You can appreciate more about the apical ballooning here. The feeling pressure shown by E over E prime and EA ratio is not particularly high. Ejection fraction was measured by Simpson's method and VTI calculated by spectral Doppler. Single beat estimation was used to estimate the VA coupling, which showed a relatively normal LV and end-systolic elastance and low arterial elastance. The right heart assessment by RVS prime, normal TRV max, and collapsible IVC, together with a relatively normal feeling pressure and low VA ratio, all suggestive that fluid overload is rather unlikely, despite the impaired LV contractility. The chest X-ray finding might be better explained by pneumonia or non-hydrostatic pulmonary edema instead of fluid overloading. Aggressive negative fluid balance, therefore, might not be beneficial in this patient. The patient was managed as pneumonia and non-STEMI. He was extubated and referred to a cardiology. A volume scan was done and showed evidence of previous myocardial infarcts of the distal LAD territories, and coronary intervention was offered. So my bring-home message of my presentation is that there is no holy grail in any echo parameters, and dynamic assessment is always recommended. We shouldn't rely on a single parameters of echo as there is no gold standard, but we have to interpret the whole picture, taking different considerations and different parameters together to give us the big picture, and to interpret the physiological changes and achieve the correct decision. And all the intensities should practice our echo and be competent. So here's the end of my presentation. Thank you.